Welcome back to another deep dive. And today we are taking a journey into, well, a pretty crucial part of your body, I guess you could say.
Mm.
The endocrine system. It's fascinating, really.
It is. It is.
So think of it like this, kind of your body's command center, right? Like this network of these specialized glands that are always sending out these, well, they're basically chemical messengers.
Right.
These things we call hormones. We've got a ton of information to unpack today from a pretty detailed nursing lecture outline. So we're diving deep into all sorts of endocrine disorders affecting your thyroid. We've got the adrenal cortex and even PCOS, polycystic ovary syndrome.
Oh, yeah. Covering a lot of ground.
We do. And then there's this whole other section on weight bias in healthcare. And to wrap it all up, we even got a practice exam.
Oh, wow.
Yeah, right. So our mission, if you will, is to like pull out the most important stuff from all of this, the stuff that's really going to like make you think and hopefully help you understand this whole complex system a little bit better.
That's right. And at its core, I mean, that's what the endocrine system's all about.
Yeah.
Maintaining this balance, keeping everything in your body regulated.
Right.
And so these glands, we're talking pituitary, thyroid, adrenal glands, they release these hormones directly into your bloodstream.
Okay.
And then those hormones, they travel all over your system acting like signals.
Right.
Controlling tons of functions, everything from metabolism and growth all the way to mood and reproduction. It's super intricate. And as you'll see, I mean, even the smallest hiccups can have some pretty significant effects.
Yeah, that makes sense. Our sources actually start by making a distinction that I think is important to highlight right off the bat.
Okay.
It's the difference between endocrine and exocrine glands.
Right.
Now, you might not immediately connect your salivary glands or your sweat glands to something like your thyroid, but, they both produce these chemical secretions.
They do.
The key difference, though, is in how they actually deliver these secretions. So exocrine glands, things like your tear ducts or sweat glands, they use ducts, right, like little tubes, to release their substances onto a surface or into a body cavity. Like take your pancreas, for instance, right? It releases those digestive enzymes through ducts into your small intestine.
Right.
But endocrine glands, they're different. They're ductless. They release those hormones right into the bloodstream, and then the bloodstream acts like a delivery system, carrying those chemical messengers to wherever they need to go in the body.
Exactly. And once those hormones reach their destination, they bind to these specific receptors.
Okay.
And that can be on the cell surface or sometimes even inside the target cells.
Right.
It's a very precise interaction, almost like a lock and key.
I see.
Now, our materials really stress the importance of categorizing hormones based on their solubility. So you've got lipid-soluble hormones, things like your steroid hormones, for example. They come from cholesterol, and they can actually pass right through the cell membrane.
Really?
Yeah, so they typically bind to receptors that are inside the cell,
Inside?
often in the nucleus, which is where they can actually influence gene activity.
Wow.
Now, because they're fat-soluble, they don't dissolve well in water, right?
Right.
So they need these protein carriers to transport them through the bloodstream, which is mostly water.
So it's almost like they need a little boat or something to carry them through.
Yeah, exactly.
That's
It's like
interesting.
it's like you need a special vehicle to transport something oily through water.
Yeah.
So that makes sense.
So the fatty hormones need a taxi service in the blood.
They do.
And then we have the water-soluble hormones, which are usually made from amino acids or proteins.
Yeah.
And these guys can't just slip through the cell membrane that easily.
Nope.
Instead, they bind to receptors that are on the outer surface of the cell membrane. And then that binding, that's what triggers a whole cascade of events inside the cell.
That's right.
But the advantage here is that these water-soluble hormones, they can travel freely in the bloodstream, no special carrier needed.
Exactly, because they dissolve so easily in water.
Okay, that makes sense. But what I find really remarkable is how our bodies actually manage to keep all these different hormone levels just right.
Yeah, it is. It's pretty amazing.
The endocrine system relies on these things called feedback loops to do that, to maintain that delicate balance. And the most common type is negative feedback. So it's like, think of the thermostat in your house.
Right.
When the room gets too hot, the thermostat tells the furnace to shut off.
Exactly.
So similarly, when hormone levels in the blood get too high, your body kind of kicks in and initiates these mechanisms to reduce their production. And then the opposite happens, right? When hormone levels are too low, production increases to get things back in balance.
Exactly. It's like this constant back and forth, like a dance, trying to keep everything stable.
Yeah, it's pretty cool. And our lecture outline actually gives a really good example of this.
Okay.
It uses the regulation of thyroid hormones.
Okay.
So when your levels of T3 and T4, those are the main thyroid hormones, when those are low, your hypothalamus, that's a part of your brain, it releases this hormone called TRH.
Mm-hmm.
And that signals your pituitary gland to release TSH, thyroid stimulating hormone.
Mm-hmm.
Then TSH travels to your thyroid gland, and it basically tells it to produce and release more T3 and T4.
Right.
But then once those levels are high enough, they send a signal back to the hypothalamus and the pituitary to like ease up on the production of TRH and TSH.
Exactly.
It's a beautifully self-regulating system, like a system of checks and balances.
It is.
But what I think is really insightful here is how even the slightest disruption in this seemingly straightforward system can lead to a whole bunch of really complex disorders.
Oh, absolutely, absolutely.
And then you've got positive feedback loops, which are a little less common, but they still play a really crucial role in certain things. So instead of trying to maintain stability, positive feedback actually amplifies a process until it reaches a specific endpoint.
Mm-hmm.
The classic example here is the release of oxytocin during childbirth.
Okay, yeah.
So as the baby moves down and stretches the cervix, that stretching actually triggers the release of oxytocin.
Right.
And then oxytocin, it causes stronger uterine contraction.
Right.
And then those stronger contractions lead to even more stretching, which releases even more oxytocin.
Exactly.
And this whole cycle, it just keeps intensifying until, boom, the baby is delivered, and then that feedback loop is broken.
That's a great example, yeah.
So, okay, now that we have like a basic understanding of how the endocrine system actually works, let's zoom in on our first set of glands.
Okay.
The thyroid gland. It's this little butterfly-shaped gland in your neck, and it's got some big responsibilities.
It does.
Our sources tell us that its main functions are the production, storage, and secretion of 3 key hormones.
Okay.
So we've got triiodothyronine, which is called T3 for short, thyroxium, or T4,
Right.
and then calcitonin.
Okay.
So T3 is the more active form of the 2 main thyroid hormones.
Okay.
And it plays a really big role in regulating your body's metabolism.
Right.
And when we say metabolism, we mean like everything. Maintaining your body temperature, producing energy, influencing your heart rate, even brain development, weight management, and digestion.
Yeah, T3 is involved in a lot.
It is. And then you've got T4. That's the more abundant thyroid hormone that's circulating in your bloodstream.
Right.
Now, it's less active than T3, but it's still really important.
Yeah.
It helps regulate metabolism, growth, energy use, and your heart function. So both T3 and T4, they essentially stimulate the metabolic activity of cells in almost all of your organ systems.
That's right.
They influence your basal metabolic rate. That's the number of calories your body burns at rest, right?
Mm-hmm.
Your oxygen consumption, how your body processes lipids, growth and development, brain function, and even the activity of your nervous system.
It's pretty incredible how much those 2 hormones affect, really.
It really is. And our notes emphasize how absolutely crucial dietary iodine is for your thyroid to be able to synthesize T3 and T4.
Right.
So that little bit of iodine that's added to salt, that's doing some pretty important work.
Yeah, it is.
Now, as we talked about earlier, the production of T3 and T4 is controlled by that negative feedback loop with TSH from the pituitary gland.
Right.
But that third hormone the thyroid produces, calcitonin, it has a totally different job.
Okay.
It mainly helps lower the levels of calcium in your blood.
How so?
Well, it inhibits the breakdown of bone tissue, it increases the excretion of calcium by the kidneys, and basically promotes the movement of calcium from your bloodstream into your bones.
I see.
But interestingly, while its release is stimulated by high levels of calcium, it doesn't seem to play a central role in the day-to-day regulation of calcium balance.
Huh, that is interesting.
It is. So let's move on to what happens when the thyroid gland becomes overactive.
Okay.
This leads to a condition known as hyperthyroidism. So this is basically a sustained increase in the synthesis and release of thyroid hormones into the bloodstream.
Mm-hmm.
And our outline points out a couple of key conditions that are often associated with hyperthyroidism.
Okay.
The first one is Graves' disease.
Right.
It's an autoimmune disorder, and for reasons that we don't totally understand yet, the body starts producing these antibodies that mimic the action of TSH.
Oh, wow.
Yeah, these kind of rogue antibodies, they bind to the TSH receptors on the thyroid gland.
Oh, okay.
And then they falsely signal it to enlarge and produce too much thyroid hormone.
So it's like they're tricking the thyroid gland.
Yeah, basically.
Wow.
And Graves' disease, it's more common in women, usually between the ages of 20 and 40.
Okay.
And things like low dietary iodine intake, infections, or times of high stress, those can sometimes play a role too. The other condition they mention is toxic nodular goiter.
Okay.
So in this case, the thyroid gland develops these nodules, which are basically abnormal growths. And those nodules, they can start producing and secreting thyroid hormones on their own.
Really?
Yeah, so they're not under the normal regulatory control of TSH from the pituitary gland anymore.
Wow.
Now, the clinical signs of hyperthyroidism can be all over the place.
Oh, okay.
They can affect a lot of different body systems because those excess thyroid hormones are essentially revving up your metabolism and making your tissues super sensitive to stimulation from the sympathetic nervous system.
So that's your fight or flight response, right?
Exactly.
Wow.
So clinically, you might see bulging of the eyes, which is called exophthalmos, and eyelid lag.
Okay.
So that's where the upper eyelid doesn't move smoothly with the eyeball.
I see.
And systemically, blood tests usually show low TSH levels and high free T4.
Okay.
And patients often experience, heat intolerance, and they develop a goiter, an enlarged thyroid gland.
Right, right.
Cardiovascularly, it can lead to a rapid heartbeat, palpitations, high blood pressure, and even an irregular heart rhythm called atrial fibrillation.
Wow, so it can affect the heart quite a bit.
It can.
Okay.
And then there's respiratory symptoms like shortness of breath, musculoskeletal effects like muscle weakness, and an increased risk of osteoporosis.
Wow.
You can even have gastrointestinal issues like diarrhea and unexplained weight loss, even if you're eating more.
So even though you have an increased appetite, you're losing weight.
Yeah, exactly. It's like your metabolism is just working overtime.
That's wild.
It is. And then there's reproductive effects like irregular periods. And neurologically, people might feel super nervous, have tremors, and have trouble sleeping.
Wow, so it really affects the whole body.
It does. Even your skin can be affected, becoming warm and moist, and you might even experience hair loss.
That's a lot to deal with.
It is.
So what's going on in the body to cause all of this?
Right. So the underlying pathophysiology of hyperthyroidism, as our notes explain, often involves this excessive stimulation of the thyroid gland. Like in Graves' disease, it's mainly due to those TSH mimicking antibodies we talked about.
Right.
This leads to more T3 and T4 being produced and released, which then increases the basal metabolic rate and overactivates the sympathetic nervous system.
Okay.
And importantly, in autoimmune conditions like Graves', that normal negative feedback loop, the one that usually regulates hormone levels, well, it doesn't work right because these rogue antibodies are basically overriding the system's controls.
So the brakes aren't working.
Yeah, something like that.
That makes sense.
So to diagnose hyperthyroidism, doctors usually take a comprehensive approach.
Okay.
It starts with a detailed medical history and a thorough physical exam.
Right.
Blood tests are super important to measure those T4 and TSH levels, and they'll often do an electrocardiogram, or ECG, to check the heart's electrical activity.
Makes sense.
And sometimes they'll order a radioactive iodine uptake test, or RAIU.
What's that?
It basically measures how much iodine the thyroid is absorbing, which can help them figure out the underlying cause of the hyperthyroidism. The main goals of treatment are to block the effects of those excess thyroid hormones and to stop their overproduction by the thyroid gland.
Okay.
And there are a bunch of treatment options, like antithyroid medications, iodine preparations, beta blockers to manage things like a rapid heart rate and tremors.
Okay.
They might use radioactive iodine therapy, which aims to destroy the overactive thyroid tissue, although that can often lead to hypothyroidism as a side effect.
Oh, wow.
Or, in some cases, they might even surgically remove the thyroid gland, which is called a thyroidectomy.
Wow.
Yeah, and our outline goes into detail about when a thyroidectomy might be necessary.
Okay.
So, for example, if the hyperthyroidism doesn't respond to medication, if a patient can't have radioactive iodine therapy, or if there's a large goiter that's pressing on the trachea and making it hard to breathe.
Right.
They often do a subtotal thyroidectomy, which means they remove about 90% of the thyroid tissue.
Okay.
The goal is to leave enough tissue to still produce some thyroid hormone.
Makes sense.
But like any surgery, there are risks, right?
Yeah, of course.
Like damage to the parathyroid glands, which regulate calcium levels.
Right.
There's a risk of bleeding, infection, injury to the laryngeal nerves, which can affect your voice. And there's even a chance of triggering a thyroid storm.
What's a thyroid storm?
Well, it's also known as a thyrotoxic crisis.
Okay.
And it's basically a really severe and potentially life-threatening worsening of hyperthyroidism.
Oh, wow.
Yeah, it can be really serious. It's characterized by a dangerously fast heart rate, a very high fever, extreme restlessness, agitation, and in some cases, even seizures.
So what do they do if that happens?
The diagnosis is usually based on those severe symptoms, along with really high thyroid hormone levels and findings on an ECG.
Okay.
Treatment is aggressive and mostly supportive.
Okay.
The goal is to bring those thyroid hormone levels down quickly using medications, manage the severe symptoms, and sometimes they might even use plasmapheresis.
Plasmapheresis, what's that?
It's a procedure where they remove and replace the patient's plasma to directly lower the concentration of thyroid hormones in the blood.
Wow, that's intense.
It is. After a thyroidectomy, really careful nursing care is crucial.
Absolutely.
They need to monitor closely for any signs of bleeding or compression of the trachea.
Right.
They check vital signs frequently, watch for signs of low calcium levels, which could mean the parathyroid glands were damaged.
Okay.
They listen for any hoarseness or noisy breathing, which could suggest laryngeal nerve damage. And they make sure oxygen and suction equipment are ready just in case.
So it's a lot of close monitoring.
It is. It is. Okay, so now let's switch gears and talk about the other side of the coin. Hypothyroidism.
Okay.
So this is a condition where you typically see high TSH levels and low free T4 levels.
Mm-hmm.
And our notes distinguish between two types.
Okay.
Primary hypothyroidism, which comes from the destruction of thyroid tissue or a problem with the thyroid's ability to make hormones.
Okay.
And then secondary hypothyroidism, which originates from a problem with the pituitary gland or the hypothalamus, which control thyroid function. The most common cause of primary hypothyroidism in many places is Hashimoto's thyroiditis.
I've heard of that.
Yeah, it's an autoimmune disorder where the body's immune system basically attacks and destroys the thyroid gland.
Oh, wow.
Yeah, other potential causes include other types of thyroiditis, treatment for hyperthyroidism that might have damaged the thyroid too much,
Okay.
not enough iodine in the diet, and certain medications like amiodarone and lithium.
I see.
And the clinical manifestations of hypothyroidism, they basically reflect a slowing down of different bodily processes.
Okay, so what does that look like?
Clinically, you might see a slower heart rate than normal, anemia,
Okay.
decreased breathing capacity,
Okay.
gastrointestinal problems like constipation and unexplained weight gain, even if someone is eating less.
So opposite of hyperthyroidism.
Yeah, basically.
Wow.
And then you can have reproductive issues like really long periods or even no periods at all.
Right.
People often feel constantly fatigued, experience brain fog, have dry skin and hair, muscle aches, general weakness, and a classic symptom is being really intolerant to cold.
So they're always cold.
Yeah, pretty much.
Yeah.
And sometimes they might even have a goiter, that enlarged thyroid gland, just like in hyperthyroidism.
Huh, interesting.
It is. It is.
So how do they diagnose this one?
It's pretty similar to hyperthyroidism. They take a detailed medical history, do a physical exam, and run lab tests to check TSH and free T4 levels in the blood.
Mm-hmm.
They might also check for thyroid peroxidase antibodies, which are usually high in people with Hashimoto's thyroiditis.
Okay.
And sometimes they use a TRH stimulation test to see how the pituitary gland responds to TRH.
Okay.
The main focus of managing hypothyroidism is to carefully assess the patient and try to get them to a euthyroid state as quickly and safely as possible.
So that means getting their thyroid hormone levels back to normal.
Right, exactly. And the cornerstone of treatment is lifelong thyroid hormone replacement therapy with levothyroxine.
I've heard of that.
Yeah, it's a synthetic form of T4.
Okay.
They adjust the dosage based on the patient's response and regular monitoring of their thyroid hormone levels.
Makes sense.
But it's important for patients to know that if they start having chest pain after starting levothyroxine, they need to tell their doctor right away.
Why is that?
Because the medication can increase the heart's demand for oxygen.
Oh, okay. That's good to know.
All right, so let's move on to another crucial set of glands, the adrenal cortex.
Okay.
This is the outer layer of the adrenal glands, which sit right on top of your kidneys,
Mm-hmm.
and they are responsible for secreting these hormones called corticosteroids,
Right, right.
which include glucocorticoids, the most famous being cortisol, and mineralocorticoids, with aldosterone being the main example.
Okay.
The adrenal cortex also makes small amounts of androgens, which are sex hormones.
Right.
So cortisol is the most abundant and powerful glucocorticoid produced by the adrenal cortex.
Okay.
And it has a ton of effects throughout the body because almost every cell has cortisol receptors. It's absolutely essential for life and helps us deal with stress.
Okay.
Cortisol helps regulate blood sugar levels, keeps blood vessels healthy, maintains fluid volume, and even acts as an anti-inflammatory.
Right.
Its release increases when we're stressed, both physically and emotionally.
So things like surgery, infections, even just like everyday stress.
Right. Exactly.
Wow, that's pretty important.
It is. And then there's aldosterone, the main mineralocorticoid.
Right.
It's crucial for maintaining fluid volume outside the cells by controlling the balance of sodium and water.
Okay.
And that plays a big role in regulating blood pressure.
Mm-hmm.
The release of aldosterone is mainly controlled by the renin-angiotensin system, which is a key hormonal system that helps regulate blood pressure.
Right.
So now let's dive into some disorders of the adrenal cortex, starting with Cushing's syndrome.
Okay.
This happens when there's too much cortisol floating around in the body.
Right.
Our notes list a few potential causes. One is a tumor in the pituitary gland that's secreting way too much ACTH, which then tells the adrenal glands to produce a bunch of cortisol.
Okay.
Or there could be a tumor in the adrenal cortex itself that's directly churning out excess cortisol without any input from ACTH.
Right.
Another possibility is ectopic ACTH production.
What's that?
That's when a tumor somewhere else in the body, like in the lung, is making ACTH.
Oh, I see.
And then a really common cause is the prolonged use of high doses of corticosteroid medications.
Oh. Yeah.
To diagnose Cushing's, doctors usually use a combination of a medical history, a physical exam, and some specific lab tests.
Okay.
They often do a 24-hour urine test to measure how much cortisol is being excreted in the urine over a day.
Right.
They might measure cortisol levels in saliva at night when levels should be low.
Okay.
Or they'll do a 1 milligram overnight dexamethasone suppression test.
What's that one do?
It basically checks if the body's cortisol production can be suppressed by a low dose of a synthetic steroid medication.
I see.
They might also do blood tests to check electrolyte levels and blood sugar, and imaging studies like CT scans or MRIs to look for tumors in the pituitary or adrenal glands.
That makes sense.
Now, the symptoms of Cushing's syndrome can be pretty noticeable and often affect multiple systems in the body.
Okay.
So you might see central obesity, which is weight gain mainly in the trunk,
Right.
along with a rounded face that's sometimes called a moon face and relatively thin arms and legs.
Okay.
They might also have fat deposits on the back of the neck and upper back, sometimes called a muffalo hump.
Oh, wow.
Yeah, and then high blood pressure, fluid retention, low potassium levels, purplish stretch marks on the skin, thin skin that bruises easily.
Oh, wow. That's a lot.
It is. And there's more. High blood sugar, muscle weakness, increased risk of osteoporosis, mood swings like depression or anxiety, and they're more susceptible to infections.
Wow. So it really can affect a lot of different things.
It really can.
So how do they treat it?
Well, the treatment really depends on what's causing it. So if it's because of long-term corticosteroid use, they try to gradually reduce the dosage or stop the medication altogether if possible.
Okay.
If it's a tumor, they might surgically remove it, use radiation therapy, or give medications that block adrenal hormone production.
I see.
Nursing care for Cushing's patients focuses on closely monitoring things like vital signs, weight changes, blood sugar levels, looking for signs of infection, assessing for blood clots, and providing really important emotional support.
Yeah, that makes sense. It sounds like it can be a tough condition to deal with.
It can be. Now let's talk about the opposite scenario. Addison's disease, which is also called primary adrenal insufficiency.
Okay.
So in this one, there's a decreased production of all three types of adrenal corticosteroids. The most common cause in many parts of the world, including Canada, is autoimmune adrenalitis.
Okay.
That's where the immune system attacks and damages the adrenal glands. Other causes can be infections like tuberculosis, infarction, or bleeding in the adrenal glands, fungal infections, AIDS, cancer that spread to the adrenals, or adrenal hemorrhage.
Okay.
The symptoms of Addison's disease can be pretty diverse, and they often develop slowly over time.
Right.
Early on, you might see progressive weakness, fatigue, unintentional weight loss, and a decreased appetite.
Okay.
Other signs and symptoms can include low blood pressure, low sodium and high potassium levels in the blood, hyperpigmentation.
What's that?
That's a darkening of the skin in certain areas like the face, neck, and the creases of the hands.
Okay.
You can also have nausea, vomiting, diarrhea, and low blood sugar.
Wow.
And because the symptoms come on so gradually and can be pretty vague, they often don't diagnose it until a significant portion of the adrenal cortex is already damaged.
Oh, wow. That's concerning.
It is.
So how do they diagnose it?
They usually do a thorough medical history and physical exam along with an ACTH stimulation test.
Oh.
That test checks how well the adrenal glands produce cortisol in response to ACTH, which is a hormone from the pituitary gland.
Okay.
They might also measure cortisol and electrolyte levels in the blood and do imaging studies of the adrenal glands.
Okay.
To treat Addison's, they have to replace those missing adrenal hormones.
Okay.
This usually means glucocorticoid replacement, typically with hydrocortisone, and mineralocorticoid replacement, usually with fludrocortisone.
Oh.
It's super important for people with Addison's to know that they need to increase their glucocorticoid dose during times of stress, like if they have surgery or get really sick.
That makes sense.
Yeah, and a serious complication of Addison's is something called an adrenal crisis.
Okay.
It's also called an Addisonian crisis or acute adrenal insufficiency.
Right.
It's basically a sudden and severe worsening of adrenal insufficiency.
Wow.
And it can be triggered by different stressors, stopping those corticosteroid medications abruptly, having adrenal surgery, or if the pituitary gland is suddenly injured. The symptoms of an adrenal crisis include dangerously low blood pressure that can lead to shock, a rapid heart rate, dehydration, severe electrolyte imbalances, low blood sugar, fever, profound weakness, confusion, and severe pain in the abdomen, lower back, or legs.
This sounds really serious.
It is. It's a medical emergency.
And so what do they do?
They need to treat it immediately with intravenous hydrocortisone and fluids and closely monitor vital signs and electrolytes in a calm environment.
It sounds intense.
It is. It is. Okay, let's shift our focus now to the female reproductive system and talk about the ovaries and PCOS.
Okay.
So the ovaries are responsible for secreting the main female sex hormones, estrogen and progesterone, and also small amounts of androgens.
Mm-hmm.
Their main job is ovulation, the monthly release of an egg from a follicle.
Right.
And this is regulated by hormones from the pituitary gland, FSH and LH.
Okay.
So FSH, or follicle-stimulating hormone, stimulates the growth of those ovarian follicles.
Okay.
And LH, luteinizing hormone, triggers the actual release of the egg, which is ovulation. Now, estrogen is super important. It's involved in the development of female physical characteristics, regulates the menstrual cycle, helps the uterine lining thicken up for a potential pregnancy, maintains bone density, and even contributes to skin and cardiovascular health.
Wow. So estrogen does a lot.
It does. It does. And then you've got progesterone, which gets the uterus ready for a potential pregnancy after ovulation and helps maintain that lining if fertilization happens.
Yeah.
Now,